I can do sporting activities, TT
Oh,
table, so many things. This is my luxury room basically.
okay. Good, 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 good.
Hello, good evening, sir.
Is it in the institute or at a home?
But this is my I'm at home.
No, I thought KGMU has given you some luxurious rooms.
Sir, I spent a lot for this house.
Chalo, good, good, very good. Excellent.
Sir, the session is open for the attendees.
Oh,
Okay.
it now open. Okay.
So, Sanjay
Amit?
sir,
Yeah.
give me. So should I start then?
Yes, sir.
Okay.
Yes, Amit, you can go ahead. We can
Yes.
start now.
Good evening, everyone. Welcome to this IN headache subsection webinar. I am Dr. Amit Shankar Singh, convener of IN headache subsection and consultant for neurologist at Fortis Hospital, Mohali. I would like to welcome Dr. Debashish Chaudhary, sir, our chairperson of the expert talk, Dr. Sanjay Prakash, sir, chair of the IN headache subsection, and esteemed panelist of this webinar, Dr. Rajesh Verma, sir, Dr. Vimal Paliwal, sir. Dr. Francis, sir, may join soon. In this webinar, this evening, we will have an expert talk by Dr. Satish Khadilkar, sir, which will be chaired by Debashish, sir, followed by an interesting headache case and headache journal club, moderated by Dr. Ravi Unial under the guidance of Dr. Rajesh Verma, sir, from KGMU Lucknow Neurology Department. Uh, it's unfortunate that Dr. Satish Khadilkar, sir, is traveling. He had a change in his flight schedule, so he was not able to deliver the expert talk live. However, he has recorded his talk and sent it to our digital team, which will be presented on this in this platform. For this session, Debashish sir is there. He will share his insights about the expert talk as well as his vast experience on the topic. Also, there is a headache quiz conceptualized by our own Dr. Sanjay Prakash sir, and it will be placed between the case and journal club and will be conducted by Dr. Manju Yadav. Now over to Dr. Sanjay for further proceedings of the webinar.
Okay. Thank you, Amit. I am Dr. Sanjay Prakash, chairperson of this subsection meeting. And along with Dr. Amit Shankar, our convener, it is our honor to host this academic event. And we welcome all faculty, panelists, and participants, especially KGMU team for agreeing just for journal club and case presentation. So we welcome all attendees here and faculties. So we have very exciting academic program here, including guest lecture, case presentation, and interesting quiz, and in the last journal club. So we encourage active participation from all attendees. Please type your question in the chat box. So we will try to answer every question. So as Dr. Amit said, we were actually very fortunate to have Dr. Satish Khadilkar. We were very excited for his lecture. But unfortunately, he is not in the live session. So he has just sent their recorded version. So we will share that recorded version. And we have a privilege to have Dr. Devashish sir. He will just chair the guest lecture session. So Dr. Devashish sir needs no introduction, but briefly, he is just currently the vice chairman and
Sanjay, leave it. Go ahead, go ahead.
Okay, just sir,
Leave it,
just
leave it.
request Dr. Devashish sir to just to chair this session, and Satish Khadilkar sir lecture will be there. Smita, just share the CV of Dr. Satish sir and then lecture. Devashish sir.
Yeah, so obviously, Dr. Satish Khalka also needs no introduction. As you all know, that he has been the past president of Indian Academy of Neurology. He is an astute clinician. His main forte is neuromuscular disorders. He has got huge number of publications, 286, and he is currently the secretary of AOMC and president of the Nerve Muscle Society. So we are indeed privileged to have his view on this interesting topic. So can we place this lecture online?
Good morning, everyone. First of all, let me thank the headache subsection of Indian Academy of Neurology to participate in this seminar. I would like to thank Dr. Debashish Chaudhary and Dr. Sanjay Prakash for this session. I had a little bit of hesitation about doing this talk because I am not a headache specialist. I am a general neurologist. So a couple of times I exchanged mails with Dr. Sanjay Prakash with my reservations about this. And he said we want to hear a general neurologist perspective about headaches in clinical practice. So that's where we are. So I have chosen 10 patients that I saw in these years to make some points that one sees in clinical practice. So when I started preparing for this talk, I thought, what is the purpose of this talk? Then I realized that most headache lectures focus on diagnostic criteria, guidelines, new therapies. But here we are going to discuss 10 patients which we commonly see in clinical practice. So let's begin. A 66-year-old woman whom I was seeing practically from the beginning of my practice for migraines. She would get episodic headaches. Her headaches will be occipital largely and then coming on to the temporal region. In some events, she got a visual aura, which was quite typical when scintillating lights will come in front of her eyes. They will grow in intensity, then in 10-15 minutes they will fade away, and then the headache will come. So she would come regularly for a follow-up once in 6 months to 1 year. She developed hypertension and diabetes over the course of time, but she was managing. She presented to me once and said, "Doctor, my aura this time is different. This is not my usual aura." And her husband said, she has been saying this, but I can't see any difference. So she has become a little unsure of herself. So because the aura had changed according to the patient, we discussed and we thought we will do a scan. And the scan showed an occipital infarction. Now this patient had a migraine with visual aura, but also had vascular risk factors. She was 66. And over a period of time, when the aura changed suddenly, she became aware that something different has happened. So I think the practice point from this patient is patients know their headaches better than we do. And when they say this is different, listen carefully. Migraine is so common that once somebody has a migraine, a lot of phenomena get associated with the migraine. And there are a lot of phenomena that are part of the migraine. But when your patient says that, look, something different is happening, I think it is very important to pay attention to what they are perceiving. And that's lesson 1. Listen to the patient saying that my migraine has changed. The second patient, 38-year-old woman, she presents with episodes, rather long episodes of facial pressure, frontal headache, nasal congestion, photophobia, and she gets this episodically. Every time it will last for 3 to 4 days, sometimes will last longer. And she has been seeing an ENT doctor because of the facial pressure and nasal congestion. And she's been told to have had sinusitis. 3 antibiotic courses she has received from various ENT consultants, and they haven't helped her. So she's landed up with a neurologist. Her
नहीं चल रहा है
clinical details of the history also suggest that in addition to nasal congestion, she's got photophobia. Some of her episodes last only for a few hours, and they start with nasal congestion, there is photophobia, then a pain comes, which is in front of the head, and there is a pressure sensation on the face, and then they vanish. So there was a possibility, according to the history, that this may not be a sinus headache, and this may actually be a migraine. I think this is very common in clinical practice. You know, we specialists are literally having a tunnel vision. Like sometimes a case goes to an ophthalmologist, a headache patient goes to an ophthalmologist, they'll think it's a refractive error. Goes to an ENT doctor, they'll think it's a sinus. It comes to us, we will think of migraine and related headaches. So we have to slightly get out of this tunnel vision to appreciate what is happening. Just an anecdote that last week I saw a patient who came to me because of chronic fatigue. And since I am a neuromuscular doctor, they thought I should analyze the chronic fatigue. The same patient had seen a movement disorder doctor, and he'd worked for Parkinson's disease with many mild abnormalities. I worked her up for myasthenia, for again finding very mild things. So just an example how we develop a tunnel vision because we are into inverted commas specialists. So sinus headache and some forms of migraine can look similar, and this slide shows you the differences. Sinus headaches often are associated with bad breath, absent sense of smell, which is quite an important thing, fever, stuffy nose, nasal discharge, nasal membrane swelling, and phlegm. On the other hand, migraine starts with this aura, which is quite disabling. Then the duration is usually between 4 to 72 hours, nausea without vomiting, and sensitivity to light and or noise. So this is one sort of overlap in clinical practice that I often see, sinus headache and migraine. So when migraine presents with cranial autonomic symptoms, it is sometimes inferred as a sinus headache. Right. Lesson 3. A 35-year-old woman presented to me with the worst headache of life, and these are her words. I have never experienced anything like this before. The peak intensity built within a few seconds. A CT scan was done at a hospital next to her home. CT was normal. She was assured that everything is all right. She was discharged. She returned a week later, and this was her MRI scan, the DSA. She was admitted and investigated, and the MRI scan showed the RCVS. So I think every thunderclap headache requires an explanation. And a CT is reassuring, but that's not the test. And the causes, just to recite them, we all know them: aneurysmal subarachnoid hemorrhage, cerebrovascular disease with evidence of vasoconstriction, which is being recognized more and more, cerebrovascular disease of non-vasoconstriction etiology, infections, non-vascular neurological causes, and the primary headache triggered by provoking factors. So this patient's diagnosis was RCVS. The lesson is a normal CT, which is so often done as the first test in thunderclap headache. A normal CT is reassuring, but that's not a diagnosis. Every patient with a thunderclap headache needs to be chased for a diagnosis. There will be a minority where you won't find anything, but in most, if you chase well, you will find an abnormality. Going on to lesson 4. A 52-year-old lady was having strictly left-sided headaches. It continued for years, never crossed midline. Multiple treatments from multiple specialists, as usually happens, had been taken, but the headache was continuing. So these are side-locked headaches. As we know, migraine being the most common headache is often unilateral, but sometime in life it changes sides, or it changes sides often, maybe prominent on one side but sometimes on the other side. When you see a side locked headache, I think secondary headaches need to be ruled out, and the diagnosis of that is made by pattern. You look for trigeminal autonomic cephalalgias, which form a sizable chunk of the side-locked headaches. Then if there's a coin-shaped headache, that is the nummular headache, and so on and so forth. So as this diagram shows you, how do you proceed with that algorithm of trying to establish a diagnosis of a side-lock headache. In this patient, with the algorithm, we came out thinking that this is hemicrania continua. So the lesson is a side-locked headache is trying to tell you something. Side-lock headache usually is within these 5 or 6 diagnoses. So I think establish that it is side-locked and then use the algorithm to differentiate the diagnosis. That's one important point in the history that I find in clinical practice. Lesson 5. A 29-year-old lady came with daily headaches, pulsatile tinnitus, and a unilateral transient visual obscuration. Her history was that usually in the mornings, but any time of the day, rapidly over a few seconds, she will start seeing blurred in one eye. She will wash the eye, it will not change anything. Positions did not change anything. It will last for a few minutes, sometimes 2 minutes, sometimes 15 minutes, and then it will recede. The vision will come back to normal. So she was basically investigated for unilateral monoocular visual symptoms, and therefore people did carotid Dopplers, MRIs with an angio, with that idea that they are dealing with some kind of a vasculopathy, either coming from the carotid or in the small blood vessels of the optic nerve. On clinical examination, her fundus was abnormal on both sides, one much more than the other. Now, in this diagram, it is not showing that well, but believe me, one side was much more than the other. And then an MRI was done, which showed all the features of raised intracranial pressure. When we went back to the MR angiogram that was done a while ago, some early features of intracranial hypertension were seen. So I think there are 2 lessons from this case, that sometimes fundus examination, which, well, we all have a fundoscope, but I find that in clinical practice, the use of fundoscope by the bedside is becoming less and less, and the tendency is to send to an ophthalmologist where the optometry and all that, the focus changes. Now, OCT definitely has helped the ophthalmologist to come to some more diagnoses more easily. But I think fundoscope is an instrument that need to be used, not only kept on your tray. And this patient had, the second lesson in this patient is that the papilledema can be asymmetrical and the initial visual symptoms may be unilateral. Now that's a rarity, but since this case I was putting up, I thought I'll put that fact as well. So the lesson is use the fundoscope for papilloedema. 1 minute with the ophthalmoscope can save you a lot of investigations. And papilledema can be asymmetric and symptoms can be unilateral. I'm sure from time to time all the senior people in the audience have seen this unilateral presentation of bilateral papilledema. Then we go to the 6th case. It's a 42-year-old executive. He came to me saying that nothing is helping me. I have daily headaches. Headaches never go away. I don't think I am tense. I'm coping up with everything that is happening, though my job is hectic. And he had failed a trial of amitriptyline, propranolol, topiramate, also sodium valproate. And he came saying that, am I a candidate for CGRP therapy? Actually, when I sort of looked at him as a clinician, he looked quite tense. Then we went into the history and he said, look, my job requires about 11 to 12 hours of actual work by the side, and I'm continuously talking to people. I'm holding 3 or 4 meetings in a day, and if there is a meeting, what can I do? I take some painkiller and do the meeting. So I said, how many do you take? Then as the history unfolded, we realized that he was really overusing the medication because his job demanded that he should be in perfect situation for every meeting many times in a day. So that turned out to be a medicine overuse headache. Now, actually, we would like to hear from others how frequently they find this. I find this to be uncommon, medication overuse headache in our Indian setup, because most people have this fear of painkillers and they don't take them that much. The painkillers and kidneys has been established in general public. So I don't see medicine overuse headache too much. But there are some like this. And unless you take a full history, you will not diagnose them. I think besides history, there is nothing else that really brings you to the diagnosis. So this is an uncommon thing that I see in clinical practice, but something that's diagnosed only by the bedside with good history taking. Then this interesting case. Headache at different ages have different reasons. So age is an important factor in trying to find the etiology. This is a 70-year-old man who was admitted under a physician in Bombay hospital, and a reference was made to me. When I went up to see the patient was being wheeled out for an MRI scan. So they said, we'll have an MRI, you examine him later. But when I cast an eye on the patient on the trolley, what you see in the picture is what it was. The scalp, the hair was lost. There was some kind of a discoloration, and the temporal arteries were standing out huge and not pulsating. So just by taking a look there, I realized that we're probably going to look at a giant cell arteritis. When he came back, we examined him. He had a left-sided ataxia and weakness, and the MRI had shown a lacune in the right deep white matter, explaining the ataxic paresis that the patient had. But going in the history, he had a bitemporal headaches which had increased for 3 months. He was having fever for 1 month. He had left-sided visual deterioration, which he had not attended to, and was having inability to eat. His sedimentation rate was 114. Temporal artery biopsy, which you see on the right, showed giant cell arteritis and a transmural inflammation. He also had a platelet count of 9 lakhs. So this was a situation of temporal arteritis. Temporal arteritis also is not very common in our situation. But when it presents with devastating neurological deficits like the visual deficits, the stroke deficits, hematological changes. Of course, this patient also had more things. He had subsequently had a scalp necrosis, a lip and tongue necrosis, and this turned out to be a very, very severe case and a kind of an advanced neglected case. So he was treated with steroids and then with MMF and aspirin and showed partial recovery. So the age. A new headache after 50 demands an explanation. After 70, it definitely does so. So age is an important factor. I mean, we know all this, but I am pulling out cases that make these points. Now, this is also a very interesting patient. He's a Tehsildar in Konkan. Now, Tehsildar job is to go in the jeep to various places, inspections and well inspections, land inspections, and things like that. So he was continuously moving in a jeep as a Tehsildar. He developed 4 days of vertex pain. So he went to Kolhapur, which is from Konkan, the closest medical center. They did a CT scan. It showed a small subdural hematoma. So the surgeon said, this is small, we need to observe it, but there is a possibility that we may have to drain it. He asked the surgeon, why did I get it? He was just 39. He did not remember any injury. But that question couldn't be answered. So he came to Bombay, seeking an explanation as to why he's developed this subdural hematoma and will it require a drainage and follow-up. Now, of course, at this stage it was very small and did not require drainage. After a few days, he noticed that when he lies down, he is better. And then he was sure that that is so, because when he sits up, the headache comes, and when he lies down, the headache goes away. And then it became quite easy for me to make the diagnosis. We did an MRI, and it showed a CSF leak in the cervical region. Probably in his travels in jeep, he must have developed a tear somewhere. And all the signs of low pressure were there. We put an epidural patch on him, and the headache also subsided, and the subdural hematoma also subsided. So this is another clinical point, that the posture and the posture related headaches you need to pay attention to. Sometimes people come out with it themselves, that this is how it is. But when not, it's a good question to ask. How are you when you lie down? So do you take rest in lie down position when the pain comes? What happens to it? SIH, just like medication overuse headache is uncommon in my practice, SIH is not all that uncommon. And every month or month and a half, I'll see one new patient who's had a leak from somewhere. We do not diagnose the site of the leak in 50% of the cases. But recently, one of our colleagues developed it, and we were not finding the reason. So she went to the United States. It had a center which specializes in CSF leaks. And discussing with that individual and then doing the test that he suggested, the prone myelogram on 3 times, the realization was that the vertebral osteophytes is one of the unexplored reasons which she turned out to have. And the leak was where the osteophyte was literally pithing the dura. And they had to suture and seal it, and last 1.5 to 2 years she's remained well. So this is a slightly underdiagnosed entity. We need to pick it up. And the causes are more than we realize, and our methods of chasing the leak need to improve, as we learned from her case. Right. So posture is not a symptom, it's a diagnostic sign in some patients. The 9th patient, the 34-year-old software engineer. He's had headaches for a long time. He's had 4 MRIs done. He's had God knows how many consultations. He's had 2 CT scans done. He's had multiple neurological opinions, and he's going from one consulting room to the other and continuously worried. So when this patient came to me, I asked him, why are you here? You know, that's another good question to ask. What brings you today to my room? And that usually tells you what is their worry or what is their pressing problem. Otherwise, most patients who are seeking second opinion or a third opinion, you get lost in the files. So this is one good question that I have found. What has brought you to me today? And in a minute he said, Doctor, my brother has died of brain tumor. I do not want to die of a brain tumor. And I am not convinced that I will not go on and develop a brain tumor. So no amount of investigation and examination was going to help this man. What required was counseling. What was required was what's bothering, to understand what's bothering him, trying to, uh, you know, uh, comfort him in that. So in this case, investigations are not going to help. So when investigations stop helping, 5 MRIs, 5 CT scans, start listening again. And then I asked him, well, you've gone to so many doctors and you had discussion with so many. So he said, doctor, the biggest problem is very few doctors have time. Very few doctors are talking to me. Some have directly seen the MRI. Some have asked a few questions and then gone to the MRI. So I think with this case, we come back to our very fundamental clinical medicine fact that listen. Often listening tells you what the problem is. Now this man, you can't sort out unless you talk to him. And the last case, 31-year-old woman, episodic unilateral headache, photophobia, nausea, and family history. And a normal examination. Very much like a migraine. Unilateral headache, photophobia, and she has been having it for a long time. There is a family history of migraine. So I saw this patient for the first time. This was her history. And then she said, a new thing has come up, that a star-like thing comes in my field of vision, and she drew it like this. She was a science student, and she had a science teacher now. She had closed either eye to realize that it was present even when she closed one eye. And that would stay there for a minute or two. There was some movement in it, and then it will go away. So this was there for about 15 days. Initially, it was for about 1.5 months. Initially once in 15 days, and then was becoming more and more frequent. So long-standing migraine and new visual aura. So I looked up a little, do long-standing migraines can then start a visual aura? And as usual, the question that you ask every time, the answer is yes from the web and the related data. So they said it's possible. Some people do get it, but it's uncommon. Now she's not had an MRI all these years because her headaches were stable, headaches were going away, not quite rightly. I mean, somebody thought that this is a straightforward migraine and no imaging is necessary. But when we did her MRI, I was actually shocked to see a neuroglial tumor with hydrocephalus. Now, I do not know what's the mechanism of that visual thing, what it changed, I don't know. But a patient who had a long history of migraine with some new change, and ghastly diagnosis came up. So I think when the migraine and nothing else is such a common clinical scenario, but I think we need to pick up the rare patients hidden amongst the common ones. And I think this is where a debate on how much to investigate comes up. Should you trust your clinical judgment and not investigate further? Should you subject everyone to a scan? But I think that can be discussed in the question and answer session. So these are the 10 lessons that I learned, one patient at a time. Believe the patient saying that headache changes. Recurrent sinus headache is often a migraine. Every thunderclap headache requires an explanation. Respect the side-locked headache. Use your fundoscope. Count the tablets when you're not finding an explanation. Headaches have an age. Posture is important. Stop chasing scans. Listen to the patients. And common things remain common, but an uncommon reason may be buried under the common. So after 3 decades of neurology practice, I'm less impressed by MRI scanners and more impressed by good history taking. I'm not saying anything new. I'm just repeating what people have said from the time of Osler. And I think that the most headache diagnoses are made before the patient enters the scanner. So I would like to thank the headache subsection committee members for arranging this talk, and I'm open for questions and answers. Thank you so much.
Devashish sir.
So I think I thank Dr. Khadilkar for a very lucid, as usual, and very astute presentation, precise, discussing the 10 cases, seen in common neurological practice. So I think, I see that there are a lot of youngsters here, and they will immensely benefit from these cases, and because these cases are going to give them a different kind of perspective. Having said that, first few things I want to clarify that, when you see patients in outpatient neurology clinics with headache, 8 out of 10 will have a primary headache. So only about 1 or 2, maybe 2 is also a very large number, 1 maybe having a secondary headache. So the challenge really becomes that how to distinguish this small fraction out of a large lot which is having migraine. And you need to actually, therefore, have a very good history and find out the subtle examination points as pointed out by him. Now, the first case he said about the aura change. Yes, a change in aura pattern is definitively a warning sign. You should actually look at the other mechanisms of transient neurological dysfunction. And as a neurologist, I think we are well trained to investigate these patients appropriately. Sometimes patients in the elderly bracket will lose their migraine character and just have the aura. In earlier days, it was called migraine equivalence. But that situation also will demand some more investigations to rule out that whether there are other underlying conditions for the only aura patients. They will give the history of migraine in the previous years, younger days, but now only the aura. I think that is more common. Having said that, also it is important to note that in Western population, the aura prevalence rate is about 25 to 30%. In India, it is less. It is about 15%. And you need to have the typical features of the aura to actually classify, because there are lots of visual symptoms that have been described by migraine patients, and not all of them are aura. The second is sinus. Yes, of course, many patients go to, ENT people. There has been a study about 20 years back in which epidemiologically they showed that, migraine patients who are reporting to the hospitals are much less with a diagnosis of migraine. And then they found out why, and because they are mostly labeled by sinus. And most important, as he has said, that, cranial autonomic symptoms, they are not uncommon in migraine. They can have rhinorrhea, they can have nasal blockage, they can have conjunctival injection, although the magnitude will be much less than attacks, but they can happen, and therefore the misdiagnosis. And of course, the general use of doing an imaging of the sinus and showing that there is something in the sinus, which is present in almost everybody in the population. So you have to need to have a radiological clinical correlation to call it as a sinus headache. Thunderclap headache, yes, it's an emergency. You should go to the furthest point to find out that what is the cause. And as he has shown that it has come up later. So initially, even if this patient had got a CT scan followed by an MRI and MR angio, it could have been normal. So the dictum is that you need to repeat, because this angiographic changes may take time to develop, and therefore you need to repeat the angio after a while, about a week later or so. So thunderclap headache, yes, there is no question about letting the steam go off, because you need to investigate these patients, because you might be dealing with a catastrophic event. A recurrent thunderclap headache, if the patient is having again and again thunderclap, very strongly suggest RCVS, and therefore it must be investigated. Side-locked headache is, Sanjay has a publication on that. It obviously, if the migraine, the hemicranial, though hemicranial, It changes the sides, sometimes left, sometimes right. But if it's side locked, then obviously it will raise a suspicion that am I dealing with some secondary headache condition. And also to tell you that, in Western literature, the hemicranial part is about 60% and holocranial is 40%. I feel this hemicranial tag is slightly deceptive, and people do not consider holocranial headaches as migraine. That's wrong. In India, it is actually the opposite. In very many studies we have done, it's about 60% holocranial and 40% hemicranial. And even if it starts hemicranially, it moves on to involve the entire head. Role of fundoscopy cannot be overestimated. All the residents should learn to do the fundoscopy at least in the bedside and the clinic, and that would give a lot of other, kind of inputs, not only a papilledema, but other things that might also be associated with migraine that might come up. Medication overuse rate, that is dependent on your practice. The practice you do as a general neurologist, you might not be seeing a medication overuse headache that much. But if you do a headache based practice, a clinic based practice, headache clinic based, you see a lots and lots of it. It's not correct that Indian patients do not take analgesics and other drugs. I mean, I see a huge number. You can come to my clinic and I'll see day in day out a huge number of intake of analgesics and triptans and even opioids by these patients. So it depends on the kind of practice you do. Probably in general neurology practice, it is not that common or not commonly picked up, but in specialized headache clinics, it's very common, and we see day in, day out. GCA is, of course, any patient having an elderly, as you said, 50 years above age, must be ruled out for GCA, and you don't wait for the results to come. You actually start because the patient might lose vision. So that is very important. SIH, I agree that it is an underdiagnosed condition, and therefore we need to keep our suspicion index high, especially an unexplained SIH, subdural that has been shown here. So that would suggest. The postural thing again is it's because if a patient is coming to you after 2 months or 3 months, then many of these patients might actually lose the postural characteristic. And unless you ask the initiation part, that initially what happened, was there any postural component, then only you will be able to diagnose. I saw last couple of years back a patient from US. He had shown major centers, but nobody took the history of postural changes in the headache during the earlier times of his headache and made it as a tension type or chronic daily headaches. Now, about the psychopathology, yes, psychopathology does play a role. But remember that, there is a general tendency to ascribe migraine and other primary headaches to a psychological condition. That's not true, because many of these patients who are having chronic migraine have a minimal depression or anxiety features, but many do, and they exacerbate the headache. They are not the cause of the headache. They actually cause the exacerbation of headache and result in chronification. So that's a very important part of your understanding of the psychopathology and the adequate treatment for that psychopathology. A little dose of amitriptyline might not help in this patient. You need to go up and treat them properly. And finally, new onset aura. Yeah, new onset aura is obviously, as I said, is a in a setting of migraine is again, you would like to, because any focal neurological dysfunction that is coming up, even though there is a classical history of migraine, that needs to be investigated, because as you know, the ICSD say in the category E that all other diagnoses have been ruled out. So before making that headache as a primary diagnosis, you must rule out. Now, question is that how often would you like to do the MR? That depends on the clinical context and history taking. If you just think that, taking the history of headache, that how many days and what is the nature, and ordering an MRI will solve the problem, as is rightly said, it will not solve the problem, because most of the headaches will come, most of the patients will come back to you with normal scans. And then you have to ask the history again. So in the first visit itself, ask at least adequate history to really note the classical features of migraine and then diagnose that. Migraine has a wide spectrum. It can be very minimal to a very, very debilitating illness. And also you should remember that headache is just one manifestation of migraine. The idea of migraine has changed now in the last decade or so. So this is basically a maladaptive sensory system of the body, and this is affecting the body in various ways. It's affecting your cognition, it is affecting your balance, it is affecting your appetite, gastric systems, it has got musculoskeletal manifestations. So it's rather a systemic disease and just not the headache. Headache is a major part of it, but then there are lots of other associated features that go along with migraine. So keeping these points in mind and keeping the note of these cases will be very helpful. And I hope that you must have all enjoyed listening to Dr. Khadilkar, which is always a pleasure. So thank you.
Thank you, sir. Thank you, sir, for guiding the guest lecture session. And there is just one question I will take here. And some Sandeep Kaur is just asked, can migraine be side locked and have autonomic feature? I have seen one young male patient in which I suspected tax, but he responded to migraine prophylaxis. I would like to, Bimal Paliwal would like to answer this question.
This is not a very easy question to answer. Largely, migraines are not side locked. They are changing sides. You can say side lock because you have seen a patient only for a small period of time. If you follow this patient over a longer period of time, you might find that either it is not migraine or it has changed sides over a period of time. So I believe that migraine is, as sir said, is very commonly holocranial. It can be hemicranial, but it's very rarely side locked. This is what I feel.
Thank you. Devashish sir, your opinion regarding
Yeah,
this?
I think I agree exactly. And he raises a very, very important point. It all depends on what time span you are seeing the patient. If you're seeing in a very minor, early stage where it's minimal dysfunction, minimal problem, then it's all right. But if you are once this, headache starts repeating itself. Now, autonomic symptoms, by and large, we say that the autonomic symptoms and the systemic features that are associated, for example, photophobia, phonophobia, they are bilateral in migraine, right? And that is one distinguishing point from tax, that when it happens in tax, it is lateralized, like lateralized photophobia, lateralized phonophobia, and obviously the side-locked autonomic symptoms. But in a given case, it may happen occasionally. You need to take the other things into consideration. That what is the duration of the headache? Is the duration long, right? Is the duration is passing 4 hours or more, right? It is actually, and is the patient having a lot of agitation during the attack or not? Whether the patient is in migraine patients will lie still, they will not move, because motion sensitive, right? So if it's a severe attack. Now, so therefore these are the other things that you should consider. And I think that occasionally you do find such cases, but you need to see the patients in a longer term to really distinguish between migraine and tax.
Okay, sir. Thank you, sir, for your guiding this guest lecture session.
Thank
Now
you.
we will move for the case presentation session. Over to Dr. Amit. So you take the
Yeah.
chance.
After this wonderful session by Dr. Khadilkar sir and a wonderful discussion by Devashish sir, I would like to call upon the KGMU Lucknow Neurology Department team. Dr. Kajal Chaudhary, Senior Resident in Neurology Department, will present a headache case, and Dr. Ravi Unial, Professor, Neurology Department, KGMU, will moderate this course. Over to Dr. Kajal.
Good evening, sir. I'll be sharing my screen now. Yeah. Is it visible, sir?
Yes, Dr. Kajal.
Yes, sir. So good evening. First of all, very good evening to all the respected panelists. At the onset, I would like to thank all the members of the eye and headache subsection team for giving me an opportunity to speak in today's session. So today I would be presenting a case of a patient with paroxysmal facial pain with some atypical clinical features that led us to explore the possibility of a link between facial pain and hypertension. So our patient was a 55-year-old female who presented to us in our OPD with a complaint of recurrent episodes of severe left-sided facial pain for the past 8 months. Her pain episodes were sudden in onset, lasted for a few seconds, and were localized to the mandibular and maxillary division of the left trigeminal nerve territory. Her pain severity was moderate to severe, and she dedicated a score of 8 on the visual analog score. She described her pain as electric shock-like or lancinating in character, and these episodes occur approximately 5 to 6 times per day. Moreover, these episodes were triggered by chewing or while she was talking, and even sometimes when she used to touch left side of her face. There was no associated pain in the inter-attack period, and there was no associated history of any photophobia, phonophobia, nausea, vomiting, conjunctival congestion, lacrimation, eyelid-facial swelling, any past history of diabetes or stroke, or any other history of dental pain or swelling. So after the detailed history and assessing the semiology of the headache, we made a list of 3 potential differential diagnoses for this patient: trigeminal neuralgia, Sang-Tarsuna, and paroxysmal hemicrania. So let's look for the points for and against each category. So trigeminal neuralgia is classically described as a unilateral facial pain which is localized to the trigeminal nerve distribution, with attacks lasting for a few seconds and being electric shock like or lancinating in character, and triggered by stimuli within the trigeminal nerve distribution. So all of these factors were present in our patient, and trigeminal neuralgia checked all the boxes of the differential diagnosis. Coming on to the Sang-Tarsuna category, our patient did have brief episodic unilateral headache lasting for a few seconds, but the patient was lacking any sort of cranial autonomic symptoms such as conjunctival ingestion, tearing, or rhinorrhea. As for the paroxysmal hemicrania category, our patient had unilateral episodes of facial pain, but the episode lasted for a few seconds, as opposed to the classical description of paroxysmal hemicrania, wherein the episodes would last from 2 minutes to 30 minutes. There was also a lack of any ipsilateral autonomic symptoms, and the classical response to indomethacin was yet to be assessed. So at this point, the case seemed to be a classical trigeminal neuralgia case, until the patient reveals something really interesting in her treatment history. So around 8 months back, when the patient developed these episodes of facial pain, 1 week after the onset of pain episode, she developed an episode of mild spontaneous epistaxis, for which she consulted a registered medical practitioner in her village. And she was told that the reason for her epistaxis was her raised blood pressure, which was found to be 170 by 110 mm of Hg at that point of time. She was started on amlodipine 10 mg, and after 2 weeks, her blood pressure normalized. But very interestingly, along with the normalization of her blood pressure, her facial pain episodes also disappeared. She discontinued her medicine around 1 month after the epistaxis episode. And to our surprise, she reported that her pain episodes recurred after discontinuing her antihypertensive medicine. So she started her medications again, and her pain episode relieved again as her blood pressure controlled. So we could find a parallel between the intensity of her blood pressure and pain episodes. So she continued this cycle for 2 to 3 times when somebody finally suggested her to consult a neurologist to get a opinion on her headache and a solution to her recurring problem. So when she presented to us on general examination, her blood pressure, since she had discontinued her medication for the past 1 month, her blood pressure at presentation was 180 over 106 mmHg. Rest of the general as well as neurological examination and systemic examination were unremarkable. We investigated her, and a routine hemogram, KFT, LFT were normal. Her metabolic profile, including fasting lipid, thyroid, HbA1c, and inflammatory markers, including ESR and CRP, were normal. We did an MRI with the Fiesta protocol, and we found that there was a loop of the ICA, which is marked by the black arrow in D, E, and F subsections of the image, was seen abutting the trigeminal nerve root, which is marked by the white arrow. The vessel was not just abutting, but we could also appreciate that there was some atrophy of the left side of trigeminal nerve root as compared to the right side. So this more or less cleared a diagnosis of a classical trigeminal neuralgia in our patient. But apart from the presence of ICA loop, there was also a presence of left side of the vertebral artery loop compressing the anterolateral medulla in the patient. So after thoroughly clinically evaluating and taking a history and doing the investigations, what we had was a patient, a 55-year-old patient with a recurrent paroxysmal lancinating facial pain localized to the left trigeminal V2 and V3 territory. The attacks were triggered by the patient talking, chewing, or maybe sometimes even touching the face. The patient had severe hypertension and otherwise normal neurological examination. The neuroimaging revealed a neurovascular conflict at the trigeminal root entry zone, and an atypical finding that the patient's pain episodes were relieved by taking antihypertensive medications. So finally, we made the diagnosis of a classical trigeminal neuralgia in this patient with a neurovascular conflict and an atypical response of the patient's pain to antihypertensive medications. So given the patient's past history of a very good response to antihypertensives, we started the patient on a combination of amlodipine and atenolol 10 and 50 mg combination for her hypertension and asked her to follow up after 2 weeks. On her first follow-up at 2 weeks, her blood pressure normalized and her blood pressure reading was 136 over 76 mmHg. And to our surprise, her pain episodes had completely subsided as her blood pressure became normalized. We continued her on the same treatment and asked her to follow up after 1 month. And even on her second follow-up, her blood pressure was within the normal range and she reported no recurrence of her episodes of pain. So was this response to her pain to antihypertensive medication just a chance phenomena, or was there actually a pathophysiological link between the pathophysiology of trigeminal neuralgia and hypertension? So one hypothesis comes from the fact that the classical trigeminal neuralgia is caused by a presence of an aberrant artery compressing the trigeminal root entry zone, leading to the focal demyelination and atrophy of the root, causing effective transmission and increased hyperexcitability of the nerve, precipitating the episodes of trigeminal neuralgia. How hypertension fits into this picture is owing to the fact that chronic hypertension can lead to vascular remodeling and leading to arterial tortuosity, which can increase the neurovascular contact at the trigeminal root entry zone, which can further perpetuate the whole procedure of focal demyelination and precipitating trigeminal neuralgia in this patient. So we did a literature review to further get insight on this phenomena. And we found a similar case report published in 2017 of a 60-year-old male who was diagnosed as classical trigeminal neuralgia and reported that his pain episode worsened during uncontrolled hypertension episodes, such as during anxiety or during excessive exertion. He also reported that he found complete resolution of his symptom after control of his blood pressure. This patient, just as in our case, was also not on any trigeminal neuralgia specific treatment. And even after a follow-up of 5 years, the patient remained pain-free only on his antihypertensive medications. Other evidence we could find were also based on large population-based cohort study. So in this study conducted in 2011 in Taiwan on around 5 lakh patients to compare the incidence of trigeminal neuralgia in patients with hypertension and without hypertension, it was found that the incidence rate of trigeminal neuralgia was significantly higher, that is 35.2 per 100,000 person year in hypertensive patients compared to 23.2 per 100,000 patients year in non-hypertensive groups. And the values were found to be statistically significant with an adjusted hazard ratio of about 1.51. Another study published recently in 2026 from China was designed to assess the prevalence of hypertension in patients with classical trigeminal neuralgia as compared to healthy controls. And even in this study, it was found that the prevalence of hypertension in classical trigeminal neuralgia was almost twice as much as, that is 48.6% as compared to those with patients with without any classical trigeminal neuralgia. This is an excerpt from the same study, wherein they have noted a finding that some patients suffering from both classical trigeminal neuralgia and hypertension even complained that the pain index increased with the aggravation of hypertension and that they could gain improvement in pain management by taking antihypertensive agent, especially vasodilators like nifedipine sustained release tablets. So all of these evidence points towards the fact that indeed the trigeminal neuralgia and hypertension do have an association with each other. Now, coming back to our patient, apart from the ICA loop abutting the trigeminal nerve root, we also had a loop of the vertebral artery compressing the anterolateral medulla. So was this just an incidental finding, or did this finding actually have some impact on our patient's disease process? So the answer to this question lies in the concept of neurogenic hypertension. So rostral ventrolateral medulla is an important brainstem control center for sympathetic outflow. So any vascular compression of the RVLM will lead to stimulation of the RVLM neurons. This will in turn lead to increased sympathetic outflow, causing increased peripheral vascular resistance and catecholaminergic activity, thus increasing the patient's blood pressure. So the presence of the vertebral artery loop over the RVLM was not just an incidental finding in our patient, but indeed was a cause of hypertension in this case. So this was a seminal paper establishing the potential of neurogenic hypertension, and was published in 1985. And they compared 53 hypertensive patients and 50 normotensive patients who were undergoing decompressive surgery for nerve vascular compression syndromes. And what they found that in the hypertensive groups, 51 out of 53 patients, that is 96% patients, had a vascular compression over the lateral medullary zone. And 76% of these patients reported a normalization of their blood pressure after the decompression surgery. So thus reiterating the role of the vascular compression of the over RVLM in hypertensive patients. So the key takeaway from today's presentation is that neurovascular conflict with compression at the trigeminal root entry zone remains an important and most common cause of trigeminal neuralgia. Hypertension is associated with an increased risk of trigeminal neuralgia and is not just innocent bystander in these cases. Vascular remodeling and tortuosity secondary to hypertension remaining the key factor behind the whole pathophysiology behind the whole process. And appropriate control of blood pressure might elevate symptoms in some patients. So we do need to do that in all of these patients. So thank you for your patient listening. And we indeed had this case published in the Green Neurology and had a correspondence to this case with the writer responding to us with a similar experience on their own. So thank you very much, respected panelists.
Very nice case presentation and a very interesting connection between trigeminal neuralgia and hypertension. Dr. Ravi, do you have some comments on the case and your understanding about the case as a moderator?
Yeah. Thank you, Dr. Amit. When we first saw this patient in our OPD, actually it evoked a sense of wonder as well as a sense of disbelief. And when we advised this patient just antihypertensive treatment, we did not give her any antineuralgia treatment. So actually we were very concerned because we know that terminal is a condition which is largely sometimes missed or undiagnosed in periphery. And if this patient does not come back, then we are going to miss an opportunity to treat such patient. But fortunately, she came back after 2 weeks and her symptoms completely relieved. And for us, this became a fantastic learning. Thank you very much.
Very nice. Dr. Francis, sir, your comment on the case, and I think you are in disbelief a little bit about how antihypertensive can treat trigeminal neuralgia. We use carbamazepine, gabapentin, and other things, but in this case, patient responded wonderfully with antihypertensive. Sir, your comments on the case?
I think we get such occasional surprises in headache and facial pain management. I think, as Dr. Kajal explained very well, I think it is hardening and tortuosity that may be compressing the trigeminal, neurons at the root entry zone. And if you look at ICSD3, there are 3 subdivisions: classical, idiopathic, and secondary.
Yes.
I think not very important practically. And when I look at the BP levels, it has gone down to 130 below 80 diastolic. So I think it will be interesting. We try to bring the BP down to like the ideal 120/80, or 120/70 in every case. Yeah. So I think it's a very good case, very interesting, and it is something new. I think for me, I don't think for all of us, but I think it is some new sort of conclusion that you had. And of course, there are two or three cases already reported, but I think it is something very novel concept, that BP controlling can reduce or totally eliminate trigeminal neuralgia. And one more thing, I have seen this pre-trigeminal neuralgia. So now I think, I must be careful about hypertension. They can get unpleasant sensation, uh, vague neuropathic kind of pain before the onset of classical trigeminal neuralgia. So now I think, we have to be careful about hypertension when such unusual facial pain or periorbital pain comes and you don't see anything there, uh, causative, there.
Yes, sir.
Thank you. I think very good case.
Yeah.
Yeah.
So there is a question also, Dr. Ravi. Dr. Alarvasi A has asked a question. In this case, antihypertensive led to headache relief. The pathophysiology of hypertension was attributed to medullary compression and sympathetic stimulation in the general reflexes. So are both different scenarios? So she is asking, are both different scenarios?
Yes, Dr. Amit, Dr. Ilavasi asked this question. Yeah.
Yeah.
Actually, we are also wondered that whether this is just a coincidence or because of this amlodipine response was found. Because here I want to say that this medullary compression has been observed in many cases. We have not seen such cases, but it has been reported that many hypertensive patients actually have such kind of medullary compression, as Dr. Kajal has shown in a paper. And people actually have done surgery also for those cases. But I don't know whether it's because of this compression this patient responded or something else. Because I actually tried in many patients after this that amlodipine can it respond to other patients of primary neuralgia with hypertension, but it did not happen in other patients. So I'm also very much concerned about it. Here I want to say something that it might be possible that there is a certain stage where terminal neuralgia has not set completely. It's just in early stage where demyelination is just started to happen and patient just started to having these symptoms. And at that time, if we reduce the blood pressure, they might improve. And the other case reports also might be such examples only. Thank you.
Yeah, there is there is a comment in the question answer. Can it be a natural history of trigeminal neuralgia? So possibly that is also possible. Dr. Rajesh Verma, sir, your opinion and your learning from this case, sir.
I think so. This trigeminal neuralgia has been attributed to hypertension. But hypertension can cause a lot of vascular remodeling, a lot of vascular changes. And you see that all the neurovascular compression over the trigeminal does not cause trigeminal neuralgia. So when there is a tortuous vessel and then there is a lot of compression or pressure effect over the nerve at the root entry zone, leading to focal demyelination and a sort of effective transmission. So then it causes trigeminal neuralgia. I think hypertension, if you go into the etiology of hypertension, especially in this age group, so there are many ways which can explain hypertension. Maybe this angiotensin, renin-angiotensin system, sympathetic overactivity, or maybe some atherosclerotic phenomena in the vasculature. But I presume because of vascular remodeling of that root entry zone with the help of antihypertensive medications, probably gives some respite to the patient. But I still believe and that neuropathic drugs should be given in these type of patients along with control of hypertension.
Very true, sir. I think we should go ahead with the next presentation.
Now we should move for an interactive quiz session. So
Yes, sir.
this is fun to test our knowledge on the headache disorders. So I request everyone who can participate here. So moving to next session.
Yes,
So
sir.
Asmita, can you please start?
Yes, sir. Dr. Manju Yadav, Assistant Professor Neurology from SBS Medical College, will moderate this. Over to Dr. Manju and Ashweta for the quiz.
Good evening, everyone. So, very warm welcome to all the participants and hope you all are excited for the quiz and ready for today's quiz. So, before we begin, I would like to go to the rules. So, there will be 10 sets with 2 questions in each set. So, we'll be having total 20 questions. And each set will have a time limit of 60 seconds, approximately 30 seconds for one question. So participants must submit their answers at the end of each set within the allotted time. And answers submitted after the time for a particular set will not be considered. So also each correct question carries 1 mark and there is no negative marking. Results will be declared in next 2 to 3 days. And in case of a tie in total marks, the participant will with a shorter response time, that is fastest overall submission, will be ranked higher. So all the best, everyone. Ashmita ji, can we please have the questions?
I think panelists can also join and give the answers.
Yeah.
Ashmita, yeah.
So set 1, question number 1. According to ICHD 3, the menstrual window for diagnosing menstrual migraine is. Question number 2. According to ICHD 3, which one is not correct for visual snow syndrome? Next set, please. Set 2, question number 1. According to ICHD 3, the duration of vestibular symptoms in vestibular migraine is which of the following? Question number 2. For a diagnosis of classical trigeminal neuralgia, MRI should demonstrate which of the following? Next set, please. Set 3, question number 1. Headache attributed to pheochromocytoma is typically which of the following? Question number 2. Which of the following is not a characteristic feature of ictal epileptic headache? Next set, please. Set number 4. Question number 1. A young patient presents with recurrent migraine-like headaches, transient hemiparesthesias, transient aphasia lasting for 6 hours, and a CSF lymphocytic pleocytosis of 120 cells per cubic mm. MRI is normal and the infectious workup is negative. The most likely diagnosis is which of the following interruptions are permitted when diagnosing status migrainosus? Next set, please. Set 5. Question number 1. A patient has a migraine attack lasting 5 days but remains able to work normally throughout. According to ICHD-3, the diagnosis is most likely which of the following? Question number 2. A patient experiences recurrent episodes of monoocular scintillations lasting 20 minutes, followed by migraine headache. Fundus examination and vascular investigations are normal. The most likely diagnosis is next set, please. Set 6, question 1. A patient fulfills criteria for chronic migraine and medication overuse headache. According to ICHD-3, which of the following is right? Question 2. What is the most common direction of pain radiation in epicrania fugax? Next set, please. Set 7. Question 1. Which autonomic signs may occur at the end of epicrania fugax attacks? Question 2. According to ICHD-3, the maximum diameter of the symptomatic area in nummular headache is which of the following? Next set, please. Set 8, question 1. Which of the following correctly identifies the minimum frequency and duration thresholds required for ICHD-3 diagnosis of hypnic headache? Question 2. Which of the following statements regarding the predominant clinical pattern in attacks is correct? Next set, please. Set 9. Which of the following best defines the unremitting subtype of hemicrania continua? Question 2. Which of the following is not an ICHD-3 diagnostic criteria for hypnic headache? Next set, please. The last set, set 10. Question 1. Which criteria carries the greatest diagnostic weight in NDPH? Question 2. Which of the following headache attacks fulfills the temporal criteria for primary thunderclap headache? Your 1 minute is done. So I hope everyone enjoyed the questions.
Very difficult questions, Manju.
So, I want to make a comment here. If you start reading the IC this criteria 3, so in the opening statement of the steering committee, they said even we are not able to memorize all the parts of this ICDS criteria of 28 pages. So it is just a guide or a help to the clinicians, and for researcher, it is a sort of mandatory exercise. So I think it is not fair with the with the contestants. So even we are
Yes.
not having I mean, it's a complete information about these criteria. If you start to read, so then a lot of the 1.1, 1.2, and then so 28 pages document.
But I am happy this time, sir, because I was able to attempt many more questions than last time.
Actually, sir, this is mostly for the residents, and we just want to check their knowledge, and we want that they should know about ICHD 3. these are the very minute findings and presentations in the
I
ICSD.
think in our OPD systems, residents and doctors dealing with headache patients, so they should have some idea about the class when they should mention uh, the sub-classification or type of headache according to this kind. We should promote, I mean to say, our residents, our doctors, headache specialists, and neurologists to make some clear, precise diagnosis that should be placed on the prescription paper.
Very
So
interesting.
I would like to take opinion of Dr. Francis, sir. Your opinion regarding this question. It is based only on ICSG theory, sir. Nothing else.
I know. And what they say, even classification committee members are not able to, remember this criteria. And now there is the next headache is that, there is ICOP edition 1, International Classification of Orofacial Pain. That is very difficult. Like dentoalveolar pain, myofascial pain, neuropathic pain, idiopathic, primary headache manifesting in the facial region. So, and if you look at the dental pain, there are some 28 subtypes, so it is very difficult. But what they say, primary, secondary level, you go up to the second digit. Just say migraine without aura, migraine with aura. You don't have to go into third digit or fourth digit or fifth digit. That is for research centers and headache centers. So I think 90% of the doctors managing headache, first and second digit will be, okay. That is what is their comment on,
Definitely, sir.
ICSD.
Our purpose is to just encourage a student to read the criteria. Otherwise, what is the way to diagnose? There is no other way. This is the best book, I think.
Absolutely.
So now we should go for the answer session for this. Just Manju, just to share the answer. So we should know what the correct answer is.
Yes. My slides visible, sir?
Yes.
Okay. So coming to the set one, the question was, one was the menstrual window for diagnostic menstrual migraine. And the answer to this is -2 to +3 days, and where day 1 is described as a day of menstruation. So, and followed by question number 2, which of the following is not correct for visual snow syndrome? The answer is C. Symptoms are consistent with typical migraine aura. All other options A, B, and C denotes visual snow syndrome. Next question, the duration of vestibular symptoms in vestibular migraine is 5 minutes to 72 hours. And for the diagnosis of classical trigeminal neuralgia, the option answer is B. This was even described in the case today. For set 3, headache attributed to pheochromocytoma is short-lasting recurrent headaches. So the answer is B. And which of the following is not a characteristic feature of ictal epileptic headaches? Answer is A. Headache typically persists for more than 4 hours. For set 4, question 1, answer is Handel syndrome, that is headache and neurological deficits with CSF pleocytosis. And up to 12-hour remission is permitted while diagnosing the status migrainosus. So answer to question 2 is B. For set 5, a patient had a migraine attack for 5 days, but was able to do work normally throughout. So basically, we have to choose the best answer option. And the answer is B, probable migraine without aura. Question 2, patient experiences recurrent episodes of monoocular. The point here is monoocular. So the answer is retinal migraine. Set 6, patient fulfills criteria for chronic and medication overuse of both. So ICSD says both diagnoses should be assigned. Answer is C. For question 2, the most common direction for epicrania fugax is from posterior hemicranial headache towards the ipsilateral eye or nose. So answer is B. Which autonomic sign may occur at the end of epicrania fugax is ipsilateral lacrimation and conjunctival injection rhinorrhea. It's allowed. And the maximum diameter for the nummular headache is 6 centimeter. The correct minimum frequency and duration pattern for hypnic headache is 10 days a month, more than 3 months, lasting for more than 15 minutes after waking up. So answer is B. And the predominant clinical pattern in TACS, it's B, that is chronic paroxysmal hemicrania is more common than episodic paroxysmal hemicrania. Also, the unremitting subtype of hemicrania continua, answer for this is B, headache is daily, continuous for more than 1 year, without remission periods lasting for more than 24 hours. And for the question number 2, which of the following is not the criteria for hypnic headache? It's it's D, presence of cranial autonomic symptoms. Autonomic symptoms are not present in hypnic headaches. Last set, which criteria carries the diagnostic weight? It's C. This is quite simple. That patient clearly remembers the onset. And last question, the time for primary thunderclap headache is less than 1 minute. That is, headache peaks in less than 1 minute. Thank you. Thank you.
So I think the answers were a little bit easy only, but yeah. So after the wonderful quiz on the diagnosis of headache disorders, we will now proceed to our final presentation, Headache Journal Club, to be presented by Dr. Prachi Mahapatra, Assistant Professor, Neurology, KGMU Lucknow. Over to Dr. Prachi for Headache Journal Club.
Good afternoon, everyone. Since I have the brunt of being the last presenter, I will try to wrap it up quickly. So I'll share my slides now. Are my slides visible?
No, not yet. Okay.
It's visible now.
Yeah, visible now.
So we have actually selected 5 recent trials which have been published in the last 2 years, which have contributed in some way to the evolving therapeutic landscape of the migraine continuum. So we all know there are 4 phases of migraine. I'll not go into the depth of that, but we have a prodrome, then aura, then we have the classical ICHD-3 defined headache phase, and then we have a postdrome phase. So what the outline of our journal will be, we will discuss some therapeutic option which has been approved for the prodrome phase, which is the prodrome trial. Then we have a non-conventional therapeutic option for the headache pain phase, which is the first non-oral gepant, which is zavegepant nasal spray. Then for the preventive therapy of headache phase, we have an already existing drug approved for hypertension, which has been repurposed for migraine, which is candesartan in episodic migraine. And we have a novel therapeutic target for preventive therapy, which are the PACAP inhibitors. And then we will expand our therapeutic options to children and adolescents, which the recently published trial of feminism by Hershey et al. In this January 2026. So first coming to the ubrogepant or the prodrome trial. So this actually, we all have the conventional teaching that we should treat early in the headache phase, but how, and this trial even extended that early to the prodrome phase, which lasts even 24 to 48 hours before migraine. So this was a phase 3 multi-center trial across 75 centers in US, a randomized double-blind, placebo-controlled and crossover trial. So the PICO for this trial is that they took adult 18 to 75 years with 1 year history of ICHD-3 diagnosed migraine having 2 to 8 attacks per month with routine prodromal symptoms followed by more than 75% in headache. So basically they had a screening period of 60 days where patient had to have at least 3 to 16 prodromal symptoms, which should be reliably followed by headache within 1 to 6 hours in more than 3/4 of the prodromal symptoms. So those patients were eligible for inclusion. The intervention was oral tablet of ubrogepant 100 mg and they had matching placebo tablets. Primary outcome was absence of moderate to severe intensity headache within 24 hours after taking drug for the qualifying prodrome. And secondary outcomes was absence of moderate or severe headache within 48 hours. There was they had to fill a e-diary where there was an option of no disability, able to function normally within 24 hours and absence of headache of any intensity within 24 hours. So
coming to the results, 1,087 participants were screened and 518 were randomized 1:1 to ubrogepant, 100 mg and placebo, and then they were switched over after taking the tablet with a 7 days washout. So 480 participants comprised the safety population, 477 comprised the modified ITT who had at least one post-randomization baseline efficacy assessment, female, and it was a female-dominated trial. So coming to the efficacy outcomes, we can clearly see that ubrogepant had there was significant reduction as compared to placebo in all three of the main primary outcomes and the main secondary outcomes. The odds of having absence of moderate or severe headache with ubrogepant was all nearly 2 times higher than that of placebo. Similar with headache within 48 hours and absence of any intensity headache within 24 hours. And coming to the safety outcome, so here we can see that adverse events were relatively more higher, but they were well matched and they were all mild. There were no adverse event leading to discontinuation or any serious adverse events leading to death. So thereby concluding that we can extend our treatment phase to as early as the prodrome phase and thereby prevent a disabling headache attack by treating the patient in the prodrome phase. So coming to the second trial, so this is the first non-oral gepant to be studied in patients who actually have contraindication to triptans and they have a lot of nausea, vomiting, and they cannot take oral medication. So this was the trial basically for that. This was again also a phase 3 randomized double-blind trial across 90 centers in the US. And they took again adult patients with migraine with or without aura with a 1-year history, onset before 15 years, 2 to 8 migraine attacks per month, but they should not be chronic migraine. They should be having episodic migraine, so less than 15 headache days per month. Again, the intervention was zavegepant 10 mg nasal spray, which was given a single dose during moderate or severe migraine attack, and comparator was a matching placebo nasal spray. Primary outcomes was pain freedom at 3 years and freedom from most bothersome symptom, which they had to select from nausea, photophobia, or phonophobia at 2 hours. And secondary outcomes, they had a variable secondary outcomes, which they tested through hierarchical testing. Coming to results, so again, 1978 participants underwent screening, out of which 1405 met the eligibility criteria, 703 received zavegepant and 702 received placebo. Again, they followed a modified ITT sort of analysis where the patient who had at least one post-baseline efficacy assessment comprised the efficacy set. Coming to results, here we can again see that the patients with zavegepant had more pain freedom at 22 hours after the treatment dose. Again, they had more freedom from most bothersome symptom as compared to placebo at 2 hours after the treatment dose. This is the forest plot showing the same, that we can see most of the outcomes are favoring zavegepant. So, and also in the safety outcome, again, all the side effects were very mild and they were mostly nasal discomfort and local side effects. Serious adverse events and adverse events leading to discontinuation was again very less. So again, thereby concluding that in patients who actually have contraindication to triptans and they have a lot of nausea and intolerable to oral medication, this can be used as a non-conventional treatment option or the first non-oral gepants for abortive therapy in migraine. So third trial, so the Candisatin, so this is I think the most relevant trial for our context because this is very easily available and just 150 rupees for 10 tablets. So previously also Candisatin has been studied with small sample size trials of 60 and 70, but this was a large trial, which is again a phase 2 multi-center trial in Norway and Estonia, again double-blind trial. So PICO for this trial was they also took a similar population of adults 18 to 64 years with episodic migraine and they should not be chronic migraine. And this was actually a phase 2 trial as the dosing of Candisatin has not been studied previously. So they used 2 doses, 8 mg and 16 mg to see if we can start and escalate to those who are intolerable to 16 mg for 12 weeks. Again, control was identically appearing placebo tablets and outcomes, primary outcome was change in monthly migraine days in weeks 9 to 12 and secondary outcomes were headache days per month, triptan use days. The patient who had 50% decrease in their mean migraine days or 50% responder rate, work absence and safety and tolerability. So here again, 1340 were assessed for eligibility, out of which 457 underwent randomization, 156 received 16, 158 mg and 151 placebo. Again, it was a female-dominated trial. Here also we can see the blue line is the placebo. This is actually the least square mean decrease from the baseline mean migraine days. So we can see maximum reduction is seen with 16 mg and 8 mg, and the difference is quite significant if we compare with placebo. Again, similar thing. We have like the change from baseline in placebo was -0.8, and as the primary outcome was comparing with 16 mg. The 16 mg, the change from baseline in monthly migraine days was 2, which is also clinically significant because the MCID for any effective treatment is at least 2 migraine days or more than 50% reduction in the number of migraine days. Again, the secondary efficacy endpoints were all significant with 16 mg candacetin as compared to placebo. And similarly, we also had similar results with for 8 mg. So if the patient is not tolerating 16 mg, we can start with 8 mg and then build up because 8 mg also had almost similar findings as compared to 16 mg. Coming to safety outcomes, so again, serious adverse events. So there was one serious adverse event noted in the candidatin 16 mg out of the 4, which was judged to be related to the drug. The patient had severe syncope and fall followed by cerebral concussion. But rest all adverse events, serious adverse events were thought not to be due to the drug. So it is also relatively well tolerated. Although we had a lot of dizziness, which could be due to decreased BP, but exactly BP measurement they have not done in this trial. So again, concluding that this is a very relatively safe choice to patients who have contraindication to propranolol or amitriptyline per se for migraine prophylaxis and very easily available in India as well. Coming to the next trial, so this is the PACAP inhibitor. So this is actually a novel therapeutic target for those who are actually even resistant to our gepants or monoclonal antibodies. So PACAP is pituitary adenylate cyclase activating peptide. So here we can see that at the trigeminal nerve endings, which is one of the proposed mechanisms for migraine headache, is that there is release of vasodilator substance at the trigeminal nerve ending, and PACAP is one of them, which similarly acts like CGMP and causes vasodilatation and thereby contributed to the migraine pathophysiology. Again, similar thing that we have multiple antibodies against CGRP, and this is one of the novel antibodies against PACAP. PICO, again, they took similar patients. They also took chronic migraine, adult 18 to 65 years with more than 8 migraine days per month. And they should have failure of 2 to 4 previous preventive therapies, either beta blocker or TCAs or gepants. And the intervention was single intravenous infusion of this PACAP inhibitors. 750 mg was the primary dose, and they also explored 100 mg exploratory dose, again matching placebo infusion. Outcome was changed from baseline in monthly migraine days during week 1 to 4, and secondary outcomes was again 50% reduction in monthly migraine days during week 1 to 4, and change in monthly headache days from baseline to weeks 1 to 4. So again, 337 were screened, out of which 237 underwent randomization. So there was a 2:1:2 randomization here. The exploratory dose was allotted one part. Mean age was 42.5 years. So here also, if we see the efficacy endpoints, we can see that the primary endpoint was again significantly more with the PACAP inhibitors as compared to placebo. Again, also clinically as well as statistically significant because we have a mean difference of 2. And more than 50% reduction from migraine days was also more with PACAP inhibitors as compared to placebo. And yeah, that's showing that it was statistically significant. And if we see the safety outcomes, because this was a relatively new drug, we can see there was one serious adverse event noted in the 750 mg group, which was a sympathetic posterior cervical syndrome, which again the adjudicating committee thought that it was not related to PACAP inhibitor. So any serious adverse event related to drug was 0. So it was again relatively very safe, and we did not have any adverse events leading to withdrawal or adverse events leading to interruption of infusion or death. Notably, there was some development of anti-drug antibodies in patients with PACAP inhibitors. That is again one of the side effects of giving monoclonal antibodies. So again, this also is a promising new therapeutic target for those difficult to treat migraine patients who have failed more than 2 to 3 medications. Coming to our last trial, so this is fremanezumab in children and adolescents with episodic migraine. Some amount of background for this trial. We know that migraine, as per the GBD 2021 studies, migraine affects 7.8% of children and adolescents, and we have 206 million prevalent cases contributing to 7.5 million disability-adjusted life years lost. The most important background for this trial is that we do not have any pediatric validation of monoclonal antibodies and gepants as yet for preventive therapy or abortive therapy in migraine. So this trial tried to answer that. The population, again, they took 6 to 17 years children and adolescent, and even this trial led to FDA approval of this drug for episodic migraine of 6 to 17 years age group. Previously, it was only more than 18 years, and this drug has now been FDA approved for 6 to 17 years. Intervention was monthly subcutaneous fremanezumab for 3 months as per the body weight. Control was again monthly matched placebo injection, and primary outcome was changed from baseline in monthly migraine days, and we have again similar secondary outcomes. Here also we had 237 randomization, and it also followed a modified ITT principle where we should have one post-baseline efficacy assessment. We can again here see that patients with fremanezumab had again significant more reduction in monthly migraine days as compared to placebo, and all of the outcomes were statistically significant as compared to placebo. If we see the safety outcomes, so there were any adverse event related to fremanezumab considered to be related to drug was 6 with 120 mg and 17 with 225 mg. Although they were all mild, the serious adverse event which were noted was transaminitis and immune thrombocytopenia, which was not again immune thrombocytopenia, but they have not exactly mentioned why this happened. But hepatitis and transaminitis side effects they have mentioned to be due to the drug. So again, this was also relatively well tolerated and safe. Again, thus expanding the therapeutic landscape to children and adolescent. So take home points from these 5 trials is that we have now evidence to treat early. Like migraine intervention may begin even during the prodrome phase. We have expanded our acute treatment options, like we have zavagapan, which provides the first non-oral gapan to be studied in abortive migraine, and intranasal delivery has its own advantages of addressing nausea and gastroparesis in patients with severe nausea and vomiting. We have now prevention beyond CGRP, which is PACAP inhibition, which represents a promising new pathway, especially for difficult to treat migraine. We have repurposed, like we have already existing drug which have been now shown to be well tolerated and proven to be efficacious as compared to placebo in migraine. And now we have evidence for pediatric migraine, which is fremanezumab, which expands the preventive options to children and adolescents. Thank you for your patient listening.
Very nice presentation, extensive presentation. I think you have covered all the new therapies going to come in migraine. I want to have few comments and then we can conclude. So I would like Dr. Vimal, sir, your experience and your opinion about these new coming therapies for the migraine.
Actually, a few days back, we listened to a talk by Ravi.
Yes.
And he compared these the G-pants with the traditional analgesics. And if you compare head to head, although there is no head-to-head trial, but if you compare them, the 50% efficacy rate in number of patients, but you'll find that they are not better than the usual analgesics that are given in migraine. So most of the trials, actually what they do is they use placebo as a control in these patients. But when we have a drug here, which is very costly, what we do is we used to try this drug in those who are refractory to the usual drugs. So that is why our experience with this is not very good. And that is true with Renumab as well as the new GPAN that we have, the only one we have here. Because we try these patients in refractory ones. Because they are very costly. We won't be giving them in usual cases. But if you give them in a treatment naive or in a patient where you would have given traditional analgesic, probably they might show as good response as you would have got from a usual analgesic. So this is my take. But we have a limited experience with these drugs, these molecules. The companies that come to us, they promote them in refractory cases. But the trials are not in refractory cases. Trials are in the usual episodic migraine. So that is an issue with these GPANs and the MAPs. And I think Dr. Sanjay has also not used much, because in our clinical practice, we don't rely more on drugs. Migraine is a lifestyle disorder.
Yes.
If we are able to counsel our patients well, then I realize that even the most difficult to treat headaches, there are two most difficult to treat headaches which have a migraine phenotype. One is a medication overuse headache and other is NDPH. We have found a reasonable amount of success in treating both these conditions just by usual drugs and counseling of patients, repeated counseling sessions, and of course, managing the psychiatric comorbidities which are there in very, very high proportion in these chronic headaches. So this is my take on these drugs.
Very true point taken, sir. Dr. Francis, your opinion regarding the newer therapies which are coming nowadays, few are in the basket.
I think it is too early to come to any definitive, conclusions. I have tried some of the samples they gave, rimegepant, and I always say you have to be careful about selecting the patient. Patients with, psychological, psychiatric comorbidities. My experience is that, none of these drugs will have much of an impact here. So you have to treat psychological comorbidity, whatever psychiatric comorbidity, then only you can. And secondly, this ubrogepant, I was there in Phoenix when this was presented for the first time, Scottsdale Headache Symposium 1.5 years back. So the question I asked, they get up to 80% prodromal symptoms. And for me, I have documented prodromal for many years, less than 20%. And for me, the commonest of the prodrome is intestinal gas formation. And this gas formation is not there in the Western documentation. So when I, discussed it, many people, join me. They also get this gas formation, but that is not there in the, American prodromal documentation. And whatever response I get is just 55%, you get, maximum 6 patients out of 10 once you give rimegepant. I have tried rimegepant in maybe in 15, 16 patients. Yeah. And nowadays I see that, comorbidities, I just don't give them. This is very expensive. So, it is very disappointing also. And then in ICOP, the classification of orofacial pain, the 7th section, the last session is psychosocial assessment of a patient, which is not there in ICST 3 or 2. So I think that is very important. Psychosocial assessment of, I think that is what Dr. Vimal was highlighting now. Psychosocial, part, I think we have to address in every patient, especially, patients coming with frequent migraine, chronic migraine. I think more,
Okay, sir.
in the, okay.
Okay, sir. Thank you, sir. Dr. Rajesh Verma, sir, your take on the newer therapies in the migraine?
So I think it is very difficult to change our traditional practices. And we have experience of treating so many patients of headache in last 25 years. In every OPD, we are getting around 30, 40 patients of headache. So what I mean to say, first, at the community level, it's still underestimated, underdiagnosed condition, and where the lot of risk factors leading to chronification of headache. And these persons with headaches are coming, I mean to say, this chronic as a chronic migraine or as a medication overuse headache. So I think the conversation is very important. When you converse with your patient, and then go into the details. I mean, taking into account the background history, how they behave in the past, and what were the advice of the consultants. I think at that time you just crack down. Yes, this patient received so many n number of headache medications, NSAIDs, or like that. That's right. And then if you just put over your clinical acumen, excluding the secondary headache disorder, and just put down this abortive therapy and preventive therapy on a very, I mean to say, in a methodical manner, and just follow up those patients, give them very good advice about, and always, I would say, you have to give them information regarding the non-pharmacological measures, which are so important, like obesity, depression, anxiety, all these things. Basically, India is basically a sort of anxious society. But I've seen so many females that are depressed or like that. So you have to control or restrict these factors for chronification. As far as these new therapies are concerned, I think there is a lot of hype, because these Western population, they want to target the CGRP and this very, very costly medication. I think, yes, we have to, as a headache specialist or when as a general neurologist, when we are dealing so many with so many patients of headache, of course, this is our moral responsibility also to try these drugs in a subset of patients where our outcome of a treatment out response is not satisfactory, and then we can convince our patient because this is yes, this is a costly therapy, and this is the results of the international literature. So, but you, of course, we can offer this therapy to subset of patients. But I think it's very difficult to change the traditional practice because if I just go back into my lifetime experience, I think many patients have got improved with this conventional drugs.
Yes, very true, sir. I think in Indian scenario we have to be very selective in using these newer therapies. Now, I will ask Dr. Sanjay Prakash for his concluding remarks, and then I will go for the
Definitely.
vote of thanks, sir. To Sanjay, sir.
So we hope
Dr.
today's
Sanjay,
discussion.
before that, you should declare the results.
Result will be declared, sir, in 2 to 3 days, sir. It will take time, sir. Digital team has some limitation.
Yeah, hardly there are 10 sets of questions. So I think it
So,
takes.
but digital team has some limitation in this regard. So we will declare and we will send you, sir, all results. Definitely, sir.
But
You
yes, but
participate,
I have
sir.
not attempted. But viewing these questions, I'm 95% correct. Actually, I assess myself actually.
Okay, sir. Just we hope today's discussion were informative and definitely it will enhance both clinical practice and academic knowledge of all of us. And without taking much time, we will be looking forward to see you at you all in the next subsection meeting. Hope you will be there. So, Meet, finally you give the vote of thanks, and after that we will wind up the meeting.
Okay, sir. After this comprehensive webinar, I think this is lasted for around 2 hours.
2 hours.
Yeah, I would like to thank Dr. Satish Kadilkar, sir, who, though he is not present here, shared his wisdom in this forum with his wonderful talk. Dr. Devashish, sir, our evergreen and most honorable chairperson, all the expert panelists, Dr. Vimal, sir, Dr. Rajesh Verma, sir, Dr. M.B. Francis, Dr. Ravi Anyal, the whole King George Medical University Lucknow team. I also want to thank IN Digital team, Mr. Bhavesh and Asmita for wonderfully conducting this webinar online. Finally, I would like to convey my deep gratitude to all the participants, attendees, and headache enthusiasts who have attended this event. And good night. Have a nice dinner. Good night, everyone, and thank you.
I have a comment here. I think
Yes, sir.
by attending this webinar today, so we have refreshed almost, I mean to say, plethora of literature, plethora of knowledge regarding the headache. I think those who have attended this webinar, they have really upgraded or refreshed their knowledge about headache in entirety, in totality, from chapter 1 to chapter 20. So that's
So I
wonderful.
think, sir, quiz was interactive.
Yeah.
It was
Which should be.
brainstorming.
I think you should be on this kaboot or like that. You know, you ask the question, and I think there should be much more clinical scenario.
Yes, sir.
Because when my resident is dealing with a patient of headache, either in ICU or I mean to say high dependency unit or in OPDs, so they must know, but their reflexes should be strengthened how to approach to this patient.
Yes.
I think we should be directed in that direction.
Thank
Okay.
you, sir.
Good
Thank
night,
you
sir.
all for
Good
your
night to all.
contributions. Thank you.
Thank you,
Hope
sir.
to see you in the next meeting.
Thank you very much. Dr.
Nice.
Sanjay, thank you very much. You have invited
Yes, sir.
our
Always
department of
welcome.
neurology, and you are part of this department. Dr. Sanjay passed DM neurology from the same place, and his, I would say, his love and affection for the department, we can see from his face. And the last point, I would like to, I would say, my younger colleagues are they are very brilliant and they are doing the fantastic job in the department. Dr. Prachi is wonderful orator, and Ravi Unial always a sort of curious mind. So that's where our department is going on, and you people should, I think, we seek your help time to time.
Thank
Great,
you.
sir.
Thank you very much.
Thank
It's
you.
great,
Good
sir.
night. Good
Bye.
night, everyone.
Thank
Good
you.
night.
Good night, Parival, Bimal.
Bye. Bye, sir.
Good
Bye,
night.
sir.
Good night. Yeah, good night.
Bye, sir.
Bye.
Bye, sir.
See
Bye,
you again.
everybody. Thank you.
Good night.